Good evening and welcome to our webinar, OCD and Tourette Syndrome, a primer for parents and families. My name is Angela Sullivan, Medical Project Specialist, and I will be your moderator for this evening. This webinar is being provided as part of the Tourette Health and Education Program, a program of the Tourette Association of America in partnership with the CDC. During tonight's webinar, we would be very happy to hear from you and include your voice in the conversation. You may ask questions or share comments using the question panel on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of the presentation. I would like to mention that funding for this webinar was made possible by our cooperative agreement with the U.S. Centers for Disease Control and Prevention. The views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. So before we get started this evening, I wanted to take a few minutes to share some information about the Tourette Association of America. You can go to the next slide, please. At the Tourette Association, we are dedicated to making life better for all people affected by Tourette syndrome and tic disorders through efforts that raise awareness, advance research and understanding, and of course, provide support. Next slide. Awareness, research, and support comprise the three main pillars of our organization, and through these, we are able to provide our community with many resources. Through social media, public relations, and news placement, as well as our youth ambassadors located across the country, we're able to raise awareness of Tourette syndrome. This is also done through advocacy and lobbying on Capitol Hill for continued funding. By providing grants and fellowships to both young investigators and other professionals, we're able to advance research and provide clinical trials on Tourette syndrome and new treatment options. The TAA has a network of chapters and support groups across the country that provide support at the state level for their communities. And in addition to this, programs at the TAA, such as online support groups, webinars like the one you'll hear today, the biennial conference, and in-person presentations, we provide support to our constituents. Next slide. Lastly, I wanted to mention that our partnership with the CDC has also allowed us to create an abundance of in-print resources. We have toolkits available for all members of our community, including providers, children, young adults, families, and most recently, we've created a toolkit for law enforcement. All of these resources are available on our website in PDF form. However, they can also be mailed to you if needed. So with that said, it is my pleasure to introduce you to our speaker this evening, Dr. Erica Greenberg. Dr. Greenberg is a child and adolescent psychiatrist at Massachusetts General Hospital and an instructor in psychiatry at Harvard Medical School. She is the director of the Pediatric Psychiatry, OCD, and Tic Disorders Program at MGH and is a co-director of the Tourette Association of America, MGH Center of Excellence. Her interests include Tourette syndrome, OCD, Tourettic OCD, ADHD, and body-focused repetitive behavior disorders. She is the primary investigator on a study evaluating a behavioral treatment for those with tic disorders and ADHD, and has authored several peer-reviewed manuscripts for TS, OCD, and related disorders. Dr. Greenberg graduated from Weill Cornell Medical College and completed her general psychiatry residency at Harvard Longwood and her child adolescent fellowship training at Mass General McLean, where she served as chief resident in both programs. Without further ado, Dr. Greenberg, please go ahead with your presentation.
Welcome everyone tonight. Thank you for listening. In terms of disclosures, I have no financial disclosures. I will be talking about treatments that are not FDA approved and many of which are off-label. I'll intend to use generic names versus brand names when discussing medicine, and I'll try to clarify whether any points I'm giving are secondary to current research or more experience-based in this particular Tourettic OCD field. So in terms of what I'm going to talk about tonight, I'm first going to speak about OCD in its typical presentation, some of the background, the science behind it, typical treatment options, and then I'm going to focus on early onset OCD, and then focus on OCD with tics and or Tourettic OCD. Oftentimes the early onset OCD and the OCD with tics overlap. And finally, I'm going to try to separate complex tics from compulsions, how to determine whether it's more of a tic or a compulsion, and from other behaviors often seen in those with Tourette and or Tourettic OCD. So what is OCD? Up until 2013, it was characterized as an anxiety disorder, but with the new DSM, the Diagnostic Manual in Psychiatry, it was placed in the obsessive compulsive and related disorders, along with other disorders that have repetitive components. And it was also moved from the anxiety disorder spectrum conditions because while oftentimes it is associated with the anxiety, it doesn't necessarily have to be a key feature of OCD. So other disorders in the obsessive compulsive related disorder chapter are body dysmorphic disorder, hoarding disorder, and trichotillomania and excoriation disorder, hair pulling and skin picking disorder respectively. And those are known as body-focused repetitive behavior disorders. And so OCD is characterized by the presence of obsessions and or compulsions. Obsessions are intrusive, unwanted, and or disturbing images, thoughts, urges that then lead to feelings of anxiety and distress, or sometimes disgust, and or sometimes a feeling of just not right. They occur over and over again, and when we're speaking about children and adults for that matter, outside of their control, they pop in. Similarly, or oppositely, compulsions are the behavior that the individual feel that they have to do with the intention of getting rid of that obsession, that unwanted feeling that was caused by the obsession. Other times, people will have compulsions in order to stop something bad from happening. So for example, having to tap something 3 times to prevent an accident. And often in compulsions, it will either be excessive or not connected realistically to what something might be designed to prevent. So for example, if you tap something 3 times, it won't actually necessarily prevent an accident, but when you are doing that, you believe that you are that's a way to get rid of that obsessive, intrusive feeling. Oftentimes, especially in kids, parents will say that they don't see any compulsions, that they might be having thoughts stuck in their head, but there's not necessarily any compulsion. And sometimes, or very often, that's because there's an avoidant part of it, where if the child is afraid that they might touch something sticky and then get really upset, they will just avoid all sticky things. And so you don't necessarily see the behaviors that would happen secondary to the obsession. Oftentimes in children too, they can't articulate the aims, and so you might ask them why they're doing what they're doing, and they won't know, and that's okay. That doesn't mean that that's different from OCD. So in order to meet criteria, again, you have to have either obsessions and or compulsions, and they have to be time consuming, meaning it needs to take at least an hour a day, and it needs to cause some degree of clinical impairment or distress. Many people will have symptoms of OCD, so people who say that they don't like to touch doors, leaving bathrooms, they don't like to touch sticky things, but they don't get in the way and they don't take up a lot of time and they don't necessarily cause distress. And in those cases, depending on that, they're either referred to obsessive compulsive symptoms or subclinical OCD. But to have a real obsessive compulsive disorder diagnosis, it has to meet that criteria of the at least an hour and the impairment and distress. And then there's a few different specifiers that one adds to it. So the first one is insight. In children, insight isn't necessarily expected to be intact. So most adults with OCD are able to say that whatever their, the intrusive thought and then the resulting compulsion, that they don't think the compulsion will really prevent this bad thing from happening, but maybe it will, but it probably doesn't. So there's insight. They realize that it doesn't necessarily make sense, but they still feel like they have to do it. That's good insight. Poor insight is when the individual really believes that these thoughts are true and that the compulsions associated with them are probably true. And then absent insight, and this is when it gets more into whether or not it sounds more delusional, but that's not what we're talking about tonight. That's when someone is completely convinced that OCD beliefs are true. In children, this is less of something that we focus on because in general, insight is less strong in kids. And it also should be noted that insight changes, especially in kids, depending on their level of anxiety. And so if you ask them when they're not in the middle of having obsessive compulsive thoughts, whether whether they really do think that there'll be a fire in the house if they don't touch every doorknob, they'll say, no, that's not true. But if push comes to shove, and it gets closer to them being in a situation where they think it might come true, they will feel like they have to do it. And in that moment, they might lose insight. That's pretty typical. The other specifier, and this is what we're going to focus on a lot more tonight, is whether or not it's tic related. And that's because up to about 25% of kids that have OCD will also have tics and/or tic spectrum disorder. It's also really important to clarify that just because, when people say in colloquial terms, oh, I'm so OCD, they often are meaning they like things very neat and straight and organized and like things a certain way. And just like that, everything is on a spectrum. And so it's important not to characterize things that are normal behavior as OCD. So rituals in children are definitely normal to a degree. So oftentimes around meals, bedtimes, they can have rituals, especially when kids are younger up through late elementary school. It can help develop a sense of mastery and control of their environment. Oftentimes, and here's a picture of a baseball team with kids with rally caps on. It can be, something that maybe, they believe in the moment, but once it's over, it's easy to put away, easy to put aside, doesn't cause distress. And so often people will say they have to wear their lucky shirt, their lucky socks, they can't wash them for the season. That, depending on what else is going on, that could all be construed as normal. And this is a chart that I really like. The link is below, and I believe it's also on the American Academy of Child and Adolescent Psychiatry practice parameters, just helping to distinguish what is OCD versus what is normal child behavior. As a rule, normal child behavior doesn't cause impairment in family functioning, and an interruption of it doesn't create severe distress in the child. Other things that you might see with OCD is that over time, it becomes increasingly bizarre, where you can still follow the logic, but it's not rational, and might become more elaborate, more demanding. And if it's not done exactly correct, it might have to be repeated. Those are the sorts of things that, especially as they take up more time, you wouldn't necessarily see in normal development. And this is also over a period of time. So you'll be seeing this for weeks, months, versus, a day here and there. And so what are the obsessions and compulsions one normally sees? So oftentimes in adults, when someone hears OCD, they think of someone who washes their hands over and over again. And while that's definitely an OCD symptom, that is by far not the only one. And certain other ones in kids are as equally common. So oftentimes you can divide the obsessions and compulsions into 4 different factors, and that's how they factor out during various factor analyses that they do for research in this. So one factor is contamination. So worried that they are going to get touch something and then going to get sick, it's dirty, and the resulting compulsions for that: washing, cleaning, grooming. So that's one. The next factor is symmetry. And so these are where kids will say that something has to feel just right, or more symmetric. So I'll often ask, if you touch one side of your arm, do you have to touch the other arm? And kids might say yes. That's associated with repeating, redoing. These are the kids that in school, if they write a letter incorrectly, they'll have to wipe it out and rewrite it. Ordering, arranging, counting, touching, tapping, and skipping ahead a bit, but I'm going to talk about this a lot more in depth. This is one of the factors that's more associated with the OCD seen in Tourette. Another category, another factor, is forbidden thoughts. And this is another one that's more often seen in kids, adolescents, and adults with a more Tourettic OCD. And these are the ones that, intrusive thoughts of bad things happening, or aggressive thoughts. What if I push someone off a ledge? What if I jump off a ledge? Scrupulosity. What if I said a bad word or think it and I'm going to go to hell? Sexual thoughts, other perverse, quote unquote, forbidden thoughts. And And it's important to note that, so a common thought, a common forbidden thought is often in the sexual realm, and it used to be if someone would have intrusive thoughts, what if they're gay, what if they're bisexual, what if they're lesbian? It's the point of it is that it has to be disturbing. So for a child, adolescent that does identify as gay, lesbian, bisexual, that thought is an OCD. They might have a thought of what if I'm straight? So it's something that feels wrong. A word that we often use in OCD that separates it from other conditions is ego dystonic. Ego, I, dystonic, bad. It's something that doesn't feel like yourself. So these are intrusive thoughts that don't make sense and don't feel right, that they then try to get out of their heads with the compulsions, but the more they try to get rid of it, the stronger it is. So for this one, this forbidden thoughts, often you'll see a lot of checking. So going to the parent, are you sure I didn't push someone down? Are you sure I'm not going to hurt myself? Or a lot of reassurance seeking, a lot of confessing over and over and over, and a lot of apologizing. The final category that we don't focus as much on, or I'm not going to focus as much on this talk, is hoarding, which tends to be a little bit different from the other three. So again, it's contamination, the forbidden thoughts, and then the symmetry counting category. You can have symptoms in any of them or one of them. It's still all OCD. Oftentimes, once you are in one category, you're less likely to suddenly start developing some from a new category, but that definitely still happens. There's lots of other symptoms. They just don't factor as well onto any of these in these four groups, or they might be in both the groups. And these are these fear of vomiting. So these are kids who can't hear the word vomit, or they become disgusted or fear that they'll get sick. Hypochondriasis. If they have a pain, they'll think it might be a rare bad illness. Those sorts of symptoms are all OCD related. So who does it affect? So it affects about 2 to 3% in children and adolescents. There's two onset periods: the early onset, which is predominantly what we're speaking about today, which is average age around 10, sometimes a little earlier in boys, prepubertal boys, about peripubertal girls, so between the ages of 8 and 12. And then the later onset is in late teens, early adulthood. The reason that the early onset is so important is a lot of studies are showing that while it overlaps with the late onset, it might have different genetics. And those of the early onset OCD are more linked to tic spectrum disorder conditions. And so therefore, those that have early onset more often have tic or tic disorders, tic-related illnesses, about, again, 25% or so. Those with early onset OCD are also more likely, again, to have tics, but to also have ADHD. That's oftentimes people think, like, how could someone have OCD and ADHD? You would think they would be opposites. I'll explain why that's not the case in a moment. But rates of OCD, of ADHD are a lot higher in this population compared to in a typical population, and also anxiety disorders. In general, if a child or adolescent has OCD, they are more likely than not to have another condition. We call them comorbid conditions because you tend to see them together. That goes with it. And as I was just mentioning, we believe that the early onset OCD, it tends to be more genetic or heritable, meaning more of it seems to be passed through genes compared to the adult onset. Not all of it, only about 50%, which means we're still trying to understand where the other 50% develops from, but it does tend to be more genetic. And we know that from the early 90s that OCD and Tourette have a lot of their genetics in common. So as I just mentioned, if a child or adolescent has OCD, it's important to look for other conditions to make sure they're not there. By far, not all kids or will have all of these. It's just important to keep an eye out so that you don't inadvertently miss something. So anxiety is pretty prevalent, 30% or greater. Tics, hair pulling, skin picking, those other disorders in the OCD category, ADHD, and then also mood disorders to a degree. In general, in terms of the characteristics, of OCD, it tends to wax and wane over time. We know that stress makes it worse. We know that when you're sick, it can be worse. Tired, it gets worse. Excitement, it can sometimes get worse, but it might come and go independent of any outside condition that we're at least aware of. And the good news is that pediatric onset OCD tends to have a better prognosis to a degree than adult onset OCD. And so when they did a pretty large study where they evaluated kids and adolescents that had OCD between 7 and 12 years later, about 50% of them either had no or subclinical symptoms, which is pretty good. We tend to think of it as a condition that can come and go and for periods of time be not present, but one might always have that tendency towards. And so it's helpful to know that over about a decade or so, many kids that have it are doing pretty well. We also know that about 2/3 to 3/4 of the children that have OCD experience response with first-line OCD treatments, which I'll talk about. Before I talk about that, though, it would be helpful to talk about the pathophysiology, fancy way of saying what we think is happening in the body that causes it to be the case. And so the presumed pathophysiology is dysfunction in a brain circuit. This brain circuit, called frontocortical striatal thalamocortical circuit, CSTC for short, and I will stick with that, is implicated in OCD. And this circuit, when it's dysregulated, is basically leads to disinhibition. And it's implicated in a lot of the disorders that we see that also occur with OCD. So in addition to OCD, this circuit disruption we see in Tourette syndrome, tic disorders, body focused repetitive behavior disorders, ADHD, and also some executive dysfunction. And a term that's often used now to think of it is impulsive compulsive disorders. Impulsive means inability to stop oneself from doing something that one wants, even though there'll be punishment, like I really want that extra cookie, so I'm gonna take it even though I know I shouldn't. Compulsive means trying to get rid of a negative feeling that's bothering you. So like with tics, or sorry, not with tics, like with compulsions in OCD. So you have this intrusive thoughts really bothering, you do a ritual or a compulsion to try to get rid of it. And both of those you see. And so basically the circuit is involved in regulating motor output, emotional experience, thinking, and cognition. And so it's this disruption that leads to OCD symptoms, tic symptoms, ADHD symptoms, etc. Interestingly, so when I write affected neurotransmitters, those are the neurotransmitters, the molecules that help the brain cells communicate, basically. And what we try to target in terms of the medications when we're trying to help those with OCD. So serotonin is implicated in this circuit, and that's our best treatments right now. But glutamate is one of the primary neurotransmitters in this target, and that's where a lot of the future research in medicine for OCD is right now, although not nearly as effective yet so far as the serotonin ones. I also think it's helpful to, there's often a set of personality or characteristics and or dysfunctional beliefs that parents often describe and are known to exist in children and adolescents with OCD. And these include having this inflated sense of responsibility, like they feel they're responsible, they can cause or prevent negative outcome situations. Something called thought action fusion, which is basically if it goes in their head, they think it's real. So you think it means it's true. And part of the treatment is helping them defuse. Overestimating threat, so feeling like things that are negative are going to be more probable. Perfectionistic and rigid, so this black and white thinking. Pervasive doubt, so just this constant feeling of not being sure, and sometimes this will express as like, I don't know if I took that person's pen, maybe I did I steal it? And then finally, inability to tolerate uncertainty, often described as they need to know. So constantly asking clarifying questions to try to get all the details. In terms of treatment options, there are two mainstays of treatment: behavioral therapy, and this cartoon, Professor Gallagher and his controversial technique of simultaneously confronting the fear of heights, snakes, and the dark, which is pretty funny, and also a shout out to Dr. Barbara Coffey, who often uses this on her slides. And then psychopharmacology, fancy way of saying medicine. So the main therapy that you really want to treat OCD is a behavioral therapy. It's a type of CBT, cognitive behavioral therapy, called exposure response prevention, ERP. And what it does is, although it sounds paradoxical, the goal is to slowly and trust, with a trusted provider, expose oneself to the disturbing thoughts, images, and situations that lead to the distress that make one want to do the compulsion or avoid, and then response prevention, committing to not engage in that compulsive behavior. Very hard, and this is where I'm talking about insight suddenly lessens as soon as the child is asked to not engage in the compulsive behavior. But over time, it's been proven that this is a really helpful way to help lessen, get rid of OCD symptoms. The exact mechanism isn't entirely clear. It's thought possibly to believe that you habituate over time, so as you get used to it, the anxiety fades. Or another possibility is that one's learning how to tolerate that distress, and then once they know they can tolerate, that ultimately leads to the reduction in anxiety. And there's an example of the type of fear ladder that's often constructed in ERP on the left-hand side. So you develop this hierarchy and you slowly work up. A cognitive piece of it is often working with the child or adolescent to figure out, to help them determine what is them and what is OCD. So if you remember that OCD is that ego dystonic, it's helping them say, was that a thought that Erica had, or was that a OCD intrusive thought? And so that's the main behavioral therapy. In terms of medications for kids, in terms of the FDA approved ones, it's fluoxetine, fluvoxamine, clomipramine, and I believe those three. Either way, what we know about FDA approval, unfortunately, is it's not always necessarily what is the most effective treatment. In OCD, it is, but not necessarily in other conditions. Either way, almost all of the SSRIs are first-line treatments for OCD. And so any of these are often used. That said, providers or child adolescent providers should stay away from paroxetine, as it tends to have the most side effects. But otherwise, and citalopram, for reasons I won't get into on this webinar, can be sometimes tricky to use because of a warning on it. But escitalopram, fluoxetine, fluvoxamine, sertraline are all very helpful in treating OCD. Sometimes people will say that you have to use fluvoxamine because it has that OCD indication. It's just as good as any of the others. It's just that it can combine with clomipramine in a synergistic way. And so if you use clomipramine, it's better, but on its own, fluvoxamine is not any more effective than the other ones. So this has the dose range that you often target. It's known that in OCD, you often need to use higher doses than you might in treating anxiety or depression. So you're often at the upper end of the dose range, and not uncommonly, even above it some of the time. And with children, adolescents tend to start low, go slow. Meaning for citalopram, one might start at 5 milligrams, fluoxetine 5 milligrams. Sertraline, I've started at 12.5 milligrams, especially in those that are younger. And one can titrate relatively quickly. The main thing to watch out for is side effects, and in general, side effects with SSRIs. So sorry, these are all SSRIs, selective serotonin reuptake inhibitors, except for clomipramine, that's in a different category. It's a serotonin reuptake inhibitor. All of them tend to have mild side effects. Nausea, possibly sleep changes, possibly They tend to be overall weight neutral. Some kids might gain weight, some kids might lose weight. They're placebo-like side effects. When people take placebo in comparison, the side effects you see with placebo are pretty similar. One that we do watch out for, especially in those that are prepubertal, is something called activation, which is not in itself dangerous, but this is when kids might get more silly, edgy, activated when you increase a dose that often goes away if it's mild over the next few days. And that's something that you watch for with every change and do one's best to avoid by going very slowly, especially in those younger kids. As kids get older, that tends to happen less and less. And while it can mean that a child can't tolerate a medicine because they got too activated, that is different from bipolar disorder. And so that's important to get across also. We also speak about how long you should be on the medicine. That's a question I get frequently, which makes a lot of sense. What the research shows is one really wants to have all the symptoms gone before one stops. So if one stops but there's still symptoms, there's a greater chance of relapse than if one stops after the symptoms are gone. And one wants to wait at least 6 months, more likely a year, before withdrawing the medicine in order to have the best chance of not having relapse. In general, safe, effective, and can be very, very helpful, but it just makes sense to think through with one's provider whether it makes sense for any one child, and I'll get into the guidelines in a moment. So a landmark study was the POT study, Pediatric OCD Treatment Study, back in 2004. And what this study was looking at was whether the behavioral therapy, at least one component of that being the exposure response, or the medicine, sertraline, was chosen, the combination of behavioral therapy and sertraline or placebo alone was most effective in helping these kids. And so it was over 100 kids aged 7 to 17 with moderate and greater OCD symptoms. In the behavioral therapy, it was about 3 months with education, exposure response, relapse prevention, other cognitive strategies. And again, sertraline, it was a fixed, flexible titration scale. So you would start between 25 and 50, and each week over 6 weeks, increase up to 200, only stopping if there was adverse effects. And that is often how we titrate it. So it's not necessarily weight-based, not necessarily age-based. It's whether it's effective or not, and or whether there's side effects. If there's side effects, you stop it or lower it. If it's helping and there are not side effects, it's more helpful to go up because, again, unless the symptoms are gone, it doesn't necessarily make sense then to stop the medicine. And so what they found was that overall, the combined group did the best. So the combination of medicine and CBT worked well. That said, combination was better than sertraline, which was better, but CBT and combined didn't completely separate. So even though that percent is larger in terms of how many kids went below the threshold on the Y box, a measure below 11, those didn't statistically separate. So when we think about starting treatment, and again, I'll get into this in a second, the main guidelines is the first thing you want to do is start CBT. That said, if one has severe enough symptoms, then starting with the combination would be most effective and what's recommended. So CBT effective, combined effective, both of those more effective than sertraline alone, and CBT and sertraline alone were both more effective than placebo. So the numbers are to a degree humbling in that was what it took for remission. However, in terms of reduction of symptoms, there was a greater response. And so you can see on the figure on the right where they started in their CY box. So that's around moderate severe, and then where they ended, and that's again where you can see the combined showed that most improvement in CY box, although in terms of the actual numbers who met remission, CBT and combined were not statistically different. However, as I'm sure most of you are acutely aware, it is very, very, very difficult to find a CBT provider. And so they did a follow-up study to see whether for the kids that were started on SSRI, sertraline alone, but were only partial responders, whether adding CBT could be effective. And they compared that to whether the provider, the medication provider, just gave instructions on CBT or whether they just continued the antidepressant. And it was clear that augmenting with the regular CBT, again, now this being a combined treatment, was significantly more effective than the person giving medications just telling instructions on it or just staying with the antidepressant alone. So in terms of treatment takeaways, the first line should always be CBT, ERP, and not just the instructions, real CBT. For SSRIs, it should be about a 3-month trial with at least 8 weeks at a maximum dose. It used to be thought that it took 2 months to get to the effective, to see any benefit from SSRIs. Now we actually know that in OCD, you'll see the biggest improvements for any dose within the first 2 to 3 weeks, and then it'll continue for another up to 2 or 3 months. But if you're not seeing that big change within the first 2 or 3 weeks, it does make sense to increase the dose. And then, like I just said, again, when the CY box, that measurement, is greater than 24, and this is per the child adolescent psychiatry practice parameter guidelines. So now symptoms are severe, time, distress, severe limitations, you want to start with the combination therapy. Oftentimes what we speak about with kids with OCD is that the medication allows them to access the therapy more. So if they're just if the insight drops too far, they just feel too anxious to do the exposures, medicine can allow them to tolerate doing some of the exposures. Briefly, I'll just touch on some factors that do affect one's response to medicine. And so this is one of the takeaways from this presentation today, which is that if one has co-occurring tics, it's possible that SSRIs alone are less effective. So in that other study, I spoke about the POT study, when they looked at kids that had OCD and tics, sertraline didn't end up separating from placebo. That doesn't mean for any one kid it might be very, very effective, but it's something to think about if an SSRI alone isn't working as well for a child that has OCD and tics. In terms of things that can augment and have been proven to augment atypical neuroleptic, that's a fancy way of saying atypical antipsychotic. That's the medicines like risperidone and aripiprazole. Those have both been shown to be effective in treating OCD with tics that wasn't responsive to an SSRI alone. Other factors that make it SSRI maybe less likely: hoarding, poor insight, and family accommodation. And this is something I often try to talk about. It's often very well intentioned. So, you know, providing reassurance, letting the child avoid doing what's going to evoke that fear. But this leads to negative reinforcement, and it actually, unfortunately, causes a lot of family impairment, distress, anxiety, mood conditions in the parents. So we work with parents too to help with that. As I just mentioned, so with OCD, if there are tics, poor insight, autism spectrum, and or severe, not mild, severe mood instability, augmenting with haloperidol, risperidone, aripiprazole are all shown to be helpful. I haven't talked about clomipramine yet. Clomipramine is actually the most effective serotonergic agent we have for OCD. However, it can be associated, or it is associated with potential more side effects, and so we don't use it as a first-line option. And lots of other possibilities, but none as effective as the serotonergic agents, at least as of yet. So now moving into tic disorders and OCD. So what we know is that in Tourette syndrome, 30 to 60% of those that have it will meet criteria for OCD. And this is compared to 2 to 3% in the general population, much, much, much more common. And that doesn't even include those that have OC symptoms or subclinical. Conversely, in OCD, we know that about 30% will have tic or tic disorders, and that's versus up to 2 to 3% in the general population. What we know is that in those that have Tourette and OCD, there does tend to often be more severe tics. And then those children, adolescents that have Tourette and OCD are also more at risk for other comorbid conditions, anxiety, depression. And I'm often asked whether the symptoms that one has an OCD versus this tic-related OCD differ, and the answer is yes. So when someone with tic disorder has OCD, or if they have OCD with tics, they are more likely to have those two categories that we spoke about, the symmetry and the bad thoughts. So in terms of obsessions, you'll have more symmetry, aggression, and then the compulsions, you'll see more of this checking, touching, writing, symmetry, and a lot of what they describe as not just right. I have to do it until it feels just right. We also know that tic-related OCD, when they do it genetically, it actually looks more similar to Tourette syndrome than to OCD without tics. And so that's something that is helpful to think about, especially because in Tourette syndrome, as I'm sure many of you are aware, you often have a lot of those other comorbid conditions. And so it's more thinking of OCD as basically just part of this Tourette syndrome spectrum disorder, that circuitry, that CSTC circuitry that I spoke about. And really interestingly, there's been recent evidence that the symptom of symmetry and exactness is actually, even though we ask about it when looking for OCD, it's more associated with Tourette, both clinically and genetically, than with OCD. And so there's this terminology, Tourettic OCD, that I use a lot, that others use often, coined by Dr. Mansueto around 2005. So Tourettic OCD, and I bet this will be familiar to a lot of you, is associated with male sex, earlier age of OCD onset. So these kids might start to have OCD around age 7, 8, 9, more OCD impairment, anxiety, also sensory, hypersensitivity from an early age, attentional difficulties, ADHD, learning disorders, impulsivity, body focused repetitive behaviors, the skin picking, hair pulling, and anxiety and depression. I should be very, very clear. It doesn't mean that if you have that, you are going to have all of those. It just means that in general, those are more frequently seen in this Tourettic OCD grouping than in a more general population. And they also tend to have these more not just right feelings. And so they'll describe more of this sensory phenomenon, feeling of incompleteness that drives the symptoms. And it's tricky because when you treat it and you say like, well, what are you afraid of about touching, you know, this again, a sticky substance? And they won't say they're afraid something bad is happening. They'll say like, I just can't do it, I'll explode. And I've heard that over and over. And so that makes it really tricky to treat on using exposure response when it's what are you afraid of. It becomes maybe more needing to use more of a habit reversal, which might be more about doing a competing response or changing around the environment or learning how to tolerate that distress associated with that discomfort. And so it can be really difficult to separate out what's a tic, what's a compulsion. So an easy solution is sometimes what's driving the behavior. So if it's like a thinking or an anxiety that you want to get rid of, again, those obsessions, it could be a compulsion. If it's more of a feeling or a sensory, might be more likely to be a tic. And just as obsession comes prior to compulsion, that premonitory urge sensation that a lot of kids with Tourette report comes prior to the tic. But sometimes it's in the middle. So a lot of children, adolescents will report having to stomp their foot, maybe in multiples of 3 until it feels just right. So there's that both compulsion component in terms of the numbers needing it 3 times, and then that just right sensory drive. Or you might have, kids will describe having a physical movement or a noise in response to a thought or feeling that bothers them. And so again, this is all Tourettic OCD. That latter one we'll sometimes call ticculsions, somewhere in between a tic and a compulsion. And so just to reiterate, oftentimes we are working really, really hard to separate What's a tic? What's a compulsion? Was it behavioral? Was it impulsive? Was it disinhibited? And so compulsions temporarily relieve the distress that's caused by an obsession. Tics temporarily relieve distress caused by this premonitory sensory urge. Impulse, that you would see ADHD and in the circuitry in general, failure to stop oneself, that's like failure to inhibit a behavior motivated by reward. Again, think of like not being able to stop yourself from taking the extra cookie. And disinhibited is just simple failure to inhibit, regardless of the consequence. Blurting something out accidentally. Not having, people will say, not having a great filter. It's top-down cortical control is one term we use. It's basically acting without thinking. And these are all things that come up in kids, adolescents, and some adults with this Tourettic OCD, and there's different treatments for each of them. And so does it matter? Is it hair splitting, or is it helpful to parse these apart? So it does matter because it could affect the treatment. And as I previously mentioned, it's possible that sometimes SSRIs might be less effective in those that have the Tourettic OCD. That doesn't mean they're ineffective. And in fact, what one often sees, and this is more experience, is that the SSRIs might help with the parts that appear more purely obsessive compulsive, but those ones that are more in the middle, the sensory driven ones, the tapping 3 times, those might need different treatment. So atypical antipsychotics, those are again the aripiprazole, risperidone, those are the ones that have been shown in studies to be helpful. But we also know that alpha agonists, clonidine, guanfacine, can be used to treat tics. And so if it's thought that it might be a more Tourettic OCD, off-label, one could try that first, always in the goal of trying to optimize and minimize medication. And it helps to think in terms of the treatment, like the behavioral treatment, what is driving the behavior? That doesn't mean finding the fear behind something, because as we just talked about, it might not be driven by fear. It means more asking, is it just not right? And then it might benefit from more habit reversal techniques. And so that's how it is really helpful to try to figure this out. And finally, I wanted to touch on something that is scattered a little bit here and there in the literature, but that I see really, really often with all of the kids, teens, adolescents that I work with. And it's something that I've dubbed impulsive aggressive compulsions. And I most often, and there's evidence genetically too that this might be related to what they call a disinhibited phenotype, seen when there's this combination of Tourette, OCD, and ADHD impulsivity. And this is when the youth feels compelled to do the last thing that they, not the OCD or Tourette, wants to do. So it'll be this intrusive aggressive thought or an impulsive aggressive thought, hit something, and then they will feel compelled to do it, and they will feel like if they don't, they will explode. And the examples I put might, if they are familiar, that's because I've had multiple people say these same ones. So de-identified, a lot of people will say these, even though every child that has that often thinks that they're alone. And, having to lick a car or a window, having to push on a bruise, whether it's their bruise or someone else's bruise, or while being in the middle of like a video game or computer game when they're about to win, turning off the game. And so I see these a lot, and I try to really make the point, it's not behavioral, it's ego dystonic. They don't want to be doing it. And that's what makes it more in this Tourettic OCD ADHD category. And in order to treat it, you need a combination, education, behavioral, and pharmacological treatments often. And so just some clinical takeaways for, I wrote children, but really anyone, well, for some of them children with OCD. So sometimes kids will say that, quote, like a voice told me to do it. And when they're really little, they might not have a way to make sense of the fact that they know it's not them that wants it, this ego dystonic again. And so that's sometimes how they characterize it. Obviously you would want to do, you would want to meet with a psychiatrist if a child says that, but more often than not, it's OCD than anything, not really worried about psychosis very, 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 very rarely that's the case. Much more often the case, it's OCD. A child saying, I'm afraid I'm gonna hurt myself, but I don't want to. What if I hurt myself? And then often they might, it might thought that they're suicidal, and one always needs to assess for suicidality because we know that depression is associated with OCD. However, these thoughts are scary. They don't want them in their head. They're afraid they might act on it versus it being a sad or sort of more, you know, this is what I think I want thought. Parents will say things like, they tell me everything. I got the play-by-play of every moment of every interaction they had. That is a confessing ritual. And reassurance seeking is another one, super, super common. Are you sure it was okay? Yes. Are you sure we're going to do that? Yes. Are you sure we're going to do that? Yes. And then finally, oftentimes, I'll ask the child, you know, if they get the but what ifs. And so you'll say, like, you know, they'll say, I'm afraid I'm going to break my arm tomorrow. Well, you wouldn't do that. Like that doesn't make any sense. You're not going to be outside. But what if I fall? Well, I don't think that'll happen. But what if I do? And you get stuck in that loop that doesn't have an ending. And this is where the parent education component can be so helpful to help remove yourself from being engaged in these rituals. It's also really important to note that what you see on the outside, what a child is doing in terms of rituals, might not be what's happening on the inside, because oftentimes OCD is an internalizing disorder. And so it might be a lot more present than they're voicing. So it's important, again, this is evaluation. And then again, if there are symmetry compulsions, this touch one side needs to touch the other, think about tics, because as we've recently learned, that one tends to be more of tics than OCD. And so, yeah, that slide we already spoke about. And so thank you very much. And now I'll take a few questions.
Wonderful. Thank you so much, Dr. Greenberg. So as she mentioned, we're now going to begin answering the questions that were submitted during tonight's presentation. If you have a question, please, as a reminder, you can still submit them through the questions pane on your control panel. If we are unable to get to everyone's questions, which is likely, here at the TAA, we do have a full-time information and referral staff who can answer your questions as well by emailing support@tourette.org or calling 1-888-4-Tourette. You can also email webinars@tourette.org, and I would be happy to connect you with Dr. Greenberg if you had any further questions. So, Dr. Greenberg, the first question we have is, do you often find Tourette-specific fears or obsessions? Example, thoughts. If you don't move the tissue box, I will tick and throw it. Or if I don't tie my shoe 5 times, my tics won't let me put my foot down.
Yeah, definitely. And that I mean, that sounds like a perfect example actually of that Tourettic OCD, where it's somewhere in between a tic and a compulsion, and then they merge. And then in terms of the treatment, it can be helpful to tackle those in each of their respective components. But that's a super, things like that are I see very often.
Great, thank you. So the next question, should doctors who have patients with OCD look for Tourettic OCD indicators in case the patient has TS as well and is underdiagnosed?
Yeah, I actually think that that's really important, and less again because there's definitely going to be any difficulty or problem with the treatment, but more because sometimes if things aren't working, but that component of it is missed, that's why. And especially the younger the child is that has OCD, the more one should just keep an eye out for tics and tic disorders. And it's, you know, what's really, again, important is if a child has OCD and tics, and the tics don't bother them, they don't get in the way, they don't cause trouble, you don't need to treat the tics. So the diagnosing of it isn't because the goal is then to try to treat every, you know, condition they have. It's more just to know that it might make sense to think about habit reversal, might make sense to think about alpha agonist, just in terms of the conceptualization. And so that's why I think the education part is part, especially to pediatricians, other psychiatrists, is so helpful, because if they do look out for that, they know what else to look out for, and you can get a more comprehensive picture.
Wonderful, thank you. Our next question, what is special about hoarding? Why is it often excluded from this discussion or discussions?
It's a big topic, and hoarding is less my expertise than the other components, but one of the things that often happens is when they do the factor analyses and the genetic studies, hoarding ends up linking to a degree with OCD, but a big component of it is separate versus the other ones that tend to cluster more together. Interestingly, there's been some studies that hoarding might factor more with attentional processes, so ADHD, executive functioning. And so if a parent comes in and says that they're hoarding, I often, and I know they also have OCD, I'll always ask about attentional difficulties and executive functioning. And what I should clarify too, in children, when I'm thinking hoarding, I'm also thinking like of adults with their houses full of clutter. We know kids don't own their own property, and so that wouldn't be possible. But sometimes, even if it looks like hoarding, it's important to ask why they're saving the objects, because it might be for a more typical OCD. I'm afraid if I don't keep 60 gum wrappers, my friend is going to get hurt tomorrow. So it's also what's behind the symptom of it.
Okay, next question. Would we expect to see more rage in a patient who has TS and OCD?
Great question. I would say, so complicated response, but basically the answer is yes. So I left that out in terms of that circuitry that I spoke about. So rage, intermittent explosive disorder, basically going from 0 to 100 is also implicated in that circuit. And so that's another thing that I always ask parents about of kids when I evaluate for OCD, because those kids do tend to be more reactive, impulsive, can have rage more often than kids without OCD. What we also know, which is just really tricky, is that so if you have then Tourette and OCD, the more symptoms you have, the more symptoms you're likely to have. And so if someone has Tourette and OCD, it's probably more likely, and again, there's spectrums for all of these, so even within that can range from mild to severe. But if one has Tourette and OCD, just by nature of, or actually this has now been shown more in studies, you would be more likely to see more rage component than if it were just OCD without the Tourette.
Great, okay. I'm gonna do a few more questions. So, do tic disorders come before OCD develops?
It depends. So the most common age that you'll see tics is usually around 9, 10, 8, 9, 10. But in tic disorders, some people see them as early as 1. Oftentimes in a more Tourette, you'll see it at age 5. And some people see OCD 7, 8. So I think it's whether or not it's more of a primary OCD with tics or Tourettic OCD where you have the tics first. Either can come first. In general, you would probably see tics before OCD if it's going to be a more Tourettic picture.
Okay. So next question. I'm curious how to shut down these what ifs that you had spoke about at the end. I know that engaging won't help, but it is so hard to shut it down, especially because rage and emotional dysregulation is also associated.
Yes. Yes, and so one thing I also always tell the parent is this is why it's so important to have a therapist, a CBT therapist, ERP involved, because you can't be parent and therapist at the same time. And that's where the therapist often comes in and tries to give you workable tools to help reduce it. When, in an ideal situation, you would be able to say something like, all right, you're allowed 5 what ifs tonight, and then I'm walking away. Tomorrow night, you're allowed 4, and I'm walking away. Okay, that's 2. Okay, that's 3. And then, the next one, okay, what do you think I'm gonna say? And so it's not just stopping it, but it's basically meeting them where they are and then pulling back, but always or ideally with the help of a therapist or books. There's online book, some are good as well, but a therapist is always exceptionally helpful.
Okay, all right, we're gonna do 2 more questions. If we get good treatment for a child with OCD, could that prevent the possibility of tic manifestation?
Probably not. I would say it's the better. So we know that tics people have different thresholds for tics. So they used to say that medications like stimulants could cause tics. The belief now is not that they cause them, but if you see tics with them, it might have unmasked what was already there. So if one is going to develop tics, they're probably going to develop tics, but that doesn't mean the tics are necessarily going to be severe. So I would still get full treatment, great treatment for the OCD, but if tics come, that doesn't mean it was a treatment failure.
Great, okay. And lastly, would you be able to speak about how to go about finding someone who is familiar with CBT for Tourettic OCD? This person specifically talking about the Los Angeles area, but if you wanted to give everyone an idea about how to go about finding somebody.
So that's the hardest question yet. It's really hard, and I really think the more we can educate people about this, the broader it will grow. The goal that I recommend is if you find a treater that knows how to treat Tourette, they often know Tourettic OCD. Those that treat OCD specifically don't always know about Tourettic OCD, and so I often use the Find a Provider on the either the TAA website, or there's the International OCD Foundation website, Find a Provider, and then it's asking them, do you work with kids that have OCD and tics? How do you treat it? But I know it's really hard, and I'm hoping online tools are going to be helpful soon as well.
Yes, so for anybody listening, we do on the TAA website have the Find a Provider tool. It's very helpful, especially if you're located across the country. You can filter it right down to your state to try and find somebody. We do have people on there that are specifically treating for CBIT and all kinds of things, so please check that out. So that is all the time we have for questions. We weren't able to get to everybody, so please reach out to us. Like I said, email support@tourette.org or webinars@tourette.org, and I would be happy to get that answer for you. So thank you again for a wonderful presentation, Dr. Greenberg. That's all the time we have for our webinar. Once the webinar is closed, all participants will receive a survey on the presentation, and we would greatly appreciate it if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of tonight's webinar. Additionally, the webinar will be posted on the Tourette Association YouTube channel. For those who are unable to participate today, we encourage you to reach out to us on social media about this webinar or for any other ideas and suggestions you may have. So on behalf of the Tourette Association, thank you again for joining us and taking the time to view our presentation. Have an excellent evening, everybody.
Thanks, everyone.